All right, welcome back and good morning on this 22nd day of March 2021. It's 5 minutes past 7 o'clock and so much to talk about this morning at a time that, the 1.19 million learners get to write their final examinations at the primary level. That is the Kenya Certificate of Primary Education. We are on the ground in different stations as examination center managers move to their various centers to deliver those examination papers so that the writing of exams can begin. But with the several panelists, we're talking about this very important matter of KCP, but also at a time that the pandemic continues to cause ravage in the country. We know that so far 2,011 people have died out of COVID-19 since the first case was reported in March 2020. We also know that the infections are now above 120,000, and this month alone having reported more than 14,000 infections. And as we continue to talk about this, there's that question about the capacity with the intensive care units, because as of now we are told by the Ministry of Health that 121 people are admitted at the ICU facilities, and I'm comparing this against what is the declared capacity according to the Kenya Medical, what is that body called, KMPDC, that is the Kenya Medical Practitioners and Dentists Council, that in December last year stated that the health facilities that were compliant with dealing with COVID-19 issues were 353, and out of this they had 827 ICU beds. Professor Osur, we're looking at this capacity, the declared capacity, against now what is being reported as 121 people admitted at these ICU facilities, yet we keep being told that ICU facilities are full. Are they full in terms of the bed capacity or in terms of the human resource capacity, or what is the real situation on the ground?
Yeah, I think when we count ICU beds, there are a lot of things which go with that. It is not just a bed that is needed. You need a bed and you need what is called a monitor. You need to have a ventilator with the monitor. You need to have a qualified theater nurse or ICU nurse. You need to have an anesthetist. So a bed is just maybe 1% of what you need to admit someone to an ICU. The other things that are needed are much more expensive, much more complicated. And so it is not just building a ward space and putting a bed. It is equipping it with the right many other equipment. Mm-hmm. It is equipping it with the right personnel. It is equipping it with the right supplies. And I don't think that is something one can do in a short time. So I know we were coming up with hospital beds for ICU, for COVID patients. We were coming up with isolation beds. We were trying to improve our ICU capacity, but this is something that requires a long time to do. Training an anesthetist takes over 10 years. Mm-hmm. You need to train a doctor before you train them as an anesthetist. So it's not something you can change in 1 year. So I think the truth is that if you get sick right now in Nairobi, because I'm in contact with a number of my colleagues all over many platforms, if you get sick now, and you need an ICU bed, you are unlikely to have it. And that's a very dangerous position to be in, because we will lose people who could have been saved. We are in a very bad situation. I think the only fallback we have right now is to reinstate those measures that have been in place and that have managed to control COVID, so that we stop the spread. Of course, also there is a vaccine and people need to take it, those who are eligible. And according to the current protocol.
And Dr. Nikal, you have worked at the Ministry of Health previously, and when you hear of such a statement that 827 beds are available for ICU, and then Professor Osur, like he is saying, it goes beyond just a bed, is the government lying to its people of the capacity that we have?
Definitely, I don't think we have the true figures. Dr. Sur is extremely right that when we say we have 1 bed capacity in ICU, people think that you have that and probably a ventilator. It is a whole composite of those equipment plus human resource and other inputs that will take care of a patient when it's put in that space where the bed is. So that is what is called an ICU bed. It's not a single bed you roll in. It is that bed, the equipment around it, the staff around it, the supplies around it, and the maintenance around it. We're not even talking maintenance. So I do not think we have 827 ICU beds in the country. That looks to me too much. And the facts are now clear. We are saying in Nairobi, we want 21. In the whole country, we have 120 something people in ICU. But we know that in Kisumu, in Nairobi, there are no ICU beds. I was in Kisumu just yesterday. And the report I have is also there. There are no ICU beds. But that, let's go back. What then do we do? I think we should look at being able to give oxygen. When we talk of ICU bed, people think a lot of ventilators. But we may also save a lot of people if we have adequate oxygen supply that can be given to people who need it. That may prevent some people going ahead to need ventilation in what we call complete ICU bed.
Right.
But what is most important is go back to the measures and actually enforce them, and then reduce the spread. What we are doing, what we are seeing, is the end of what we have not done.
Right.
So as we are struggling with the emergency measures now, we must go back and enforce the guidelines properly, particularly social distancing. That has failed in my mind.
Right, and obviously, Dr. Ngekal, that's true that if all of us focused on stopping or breaking the chain, then we would not even need to worry about the ICU capacity. But Dr. Victor Ngani, because you're a critical care doctor at the front line quite a bit, so when we witnessed 98 people dying in just a week, is there evidence that the virus is becoming more severe, or are we witnessing a situation where people with underlying conditions are being attacked more than was happening at the earlier days of the pandemic?
Well, I think it's both. We are having easier infections, we are having more widespread cases, and then certainly throughout this pandemic, those who have underlying conditions, those above 65 years of age, any form of decreased immunity, and in fact, even obesity. Many of these people are getting very severe disease. But in March of 2021, where we are now, we are seeing a bigger proportion of very young people who have no underlying conditions in their 20s, 30s, and 40s, not even obese, but having very critical disease and even death. I was seeing a report yesterday from Brazil showing the exact same scenario. And therefore, there's a lot that we're yet to learn from this disease, and unfortunately, the numbers are going up. Allow me to comment on the question of ICU beds, and already you can see lack of congruence in the data that's being reported in terms of capacity and in terms of the numbers. Because the fact is, as of most of this week, getting an ICU bed in Nairobi that has normally more than 50% of all ICU beds in the country was impossible. And so if we had 800 beds, that would mean over 400 in Nairobi. Either we have 400 patients in ICU, or we don't have 800 beds for critical care. And again, as my seniors have already mentioned before, there's a huge difference between an ICU bed and a functional ICU bed. You could label a whole hospital ICU, but unless you're able to take care of a critical care patient, it's very difficult.
And Dr. Ngani, of course, it's important that even as we sensitize Kenyans, of course, the general public, it is important to understand the severity of the disease and what it does to you, because we've heard of people testing positive on a Monday, admitted to ICU on a Tuesday, and by Friday, we're already in mourning. What's happening?
Well, the disease is actually quite severe. And the misfortune is that for every 1,000 people who contract COVID-19, about 930 thereabout in Kenya will have mild disease, either a cough, some fever, some joint pains. You know, they may feel extremely sick, but it doesn't affect their lungs as badly, or the other special organ systems. But then for 7%, about 70 people, the disease is actually quite distressing. You're actually flooding on the inside. Your lungs are filling with water, and this can be very rapid in progression to a point where if you don't get access to oxygen in a very short time, you will not make it. We've had patients who are walking in the morning, they're perfectly fine. When they're walking in, the oxygen is at 20-30%, and they're almost gasping. If they don't get access to oxygen right there and then, they will not make it. And this is what we are seeing across the board. And perhaps it's important to mention that as a country, we have a very strong reporting culture, benchmarking culture, giving guidelines and issuing directives. But we've lost a whole year to improve our capacity. We've lost a whole year, because a lot of the COVID-19 patients dying today are dying because of lack of oxygen. And I think it's something we need to just take note of and start today. If we didn't do it yesterday, let's start today and actively change how we are handling this. Because the truth is that unless we wake up, and I don't think we have. I'm looking at the public today, even on social media, we're having discussions and people are questioning whether this thing is real. It is real, and the people who are dying very quickly. And it's one of the biggest disasters that we have to wake up to right now and begin to put active measures around.
And I recall speaking to one Cyrus Oguna, the government spokesperson, in December last year, Dr. And he told me that at one point his oxygen levels were at 26%, yet he made a positive recovery, or rather he recovered from the disease. What are the chances of survival? Earlier on in the pandemic, I spoke to the Secretary General of KMPDU, and he said that the chances of survival are very slim once you slip into ICU. What have you witnessed, and what is this that is taking people so fast?
Well, so the biggest challenge in attending to a COVID-19 patient who is critical, because there's a level called critical beyond severe, is where your lungs are basically all eaten up and flooded. It can go up to more than 70 or even 80% of your lung full of water. And it means that air cannot displace that. It's something called acute respiratory distress syndrome, where the lungs are fully flooded. And in this situation, no matter how much air gets into your lung, it's not enough. And so we have to use a ventilator to sort of force air into your lung, give you pure oxygen, and put it under pressure. And beyond that, COVID also affects other organ systems, including the heart, including the GIT tract, and many other systems. Now, first wave around October, November last year, we had pretty unpleasant outcomes. But right now, for high-level facilities, for example, where we work, we've made a couple of changes. We're able to save a couple of patients. The problem is going to be if these systems are overwhelmed. Right now, for us, for example, anybody who doesn't require to go to ICU, we're expecting 100% progress home if we work together with the family, because we're also getting challenges where patients are demanding to go home only to come back dead in the parking. And it's a very unfortunate situation because it's not understood. Then for those who get on ventilator, then if you get the ventilator that is outside, non-invasive, again, that gives you an advantage. But those who end up with the tube inside, the outcomes are pretty dire. We've made some improvements now, and I think we're seeing a lot more of these patients come out. But this kind of capacity is not in very many facilities. It's pretty much one of the things we ought to have created over the last 1 year, and we weren't successful. I think as a country, we missed an opportunity, but I'm saying it's something we need to start today to create that fund supporting these critical cases.
Okay, all right. Dr. Just finally, so that we can let you go, what is the lowest oxygen level you've had to treat and the patient has made a full recovery?
A patient walked in with oxygen levels of 18%. We couldn't believe it. It's the lowest we've ever seen. But in fact, when the patient got oxygenation and was able to make it eventually, it's a very, very difficult situation. There are patients who, when you give high flow oxygen via and with a mask, the oxygen levels are in the range of 40%. 40%, and you're taking in pure oxygen. Those are very, very difficult circumstances. But we're seeing more and more of these patients making it. Unfortunately, the risk of not making it is much higher than the risk of making it. And it's not something that many people understand, because someone reports having had a mild cough, some difficulty breathing, some chest pain, they felt really bad about it, and then they took garlic and they felt better. They don't realize that's a completely different ballgame. Yes, it's COVID, but a completely different ballgame from the ones that are giving us sleepless nights as doctors in ICU, the ones that are making us, sound this alarm. And if you look around social media today, many doctors involved in critical care, involved in taking care of severe critical COVID-19 are saying, hey guys, wake up, there's a crisis going on. And that alarm bell hasn't quite hit home. And I hope that we allow ourselves to hear from those who are dealing with it now, rather than hear it from the disease itself, which is also going to happen if we don't take measures.
Dr. Vitangani, we'll never have enough time to talk about this, but thank you so much for your time as you continue the rest of the conversation. Dr. Chris Omalwa. Before we close. No, we're not closing. Yeah, Dr. Chris Omalwa, I'm coming to you because, I mean, you come from Kiminini.
I want to ask him a question.
Oh, okay. Dr. Chris, go ahead. Ask Vitangani the question.
Yeah, I want to ask Dr. the question. Do we have any empirical study that has been done locally so that we can be able to trace, so that we can be able to establish? Are there specific groups? Because when these people reach the level of ICU, I expect you as a medical doctor, you need to do something, background search, so that you do an empirical study so that people can be able to know these most infections that you are getting, they are coming as a result of what? Is it because they never put on the masks, or maybe the masks we are putting on, maybe they are of poor quality? That's why we are having this high rate of infections. Is it aspect to do with social distancing? Is it aspect to do with sanitization? So we need a local empirical study to be able to inform even the medical fraternity, to be able to know where is the contribution, which factor is contributing to this high infection rate.
All right, Dr. Ngani, your answer?
Yes, I thank you for that very good question. Actually, many of the people we are seeing in ICU now are unfortunate victims of carelessness by the average Kenyan who doesn't understand that COVID is real. It's the consequence of the son or daughter who says that I cannot go a month without seeing my parent. It's the consequence of politicians and other people who go about and have rallies all across. And it's the consequence of those of us who don't understand that masking and hand hygiene is important. It's a consequence of carelessness within the public. And many of these people are elderly people who rarely leave their homes, who are always diligent in what they do, who listen to instructions, but then they contract COVID-19 from somebody else who's much younger, who doesn't have symptoms. And this is what we are seeing. And the reason for this is a lot of people, unless they're directly affected, they don't understand COVID is there. It's only after they've gotten a direct impact that they begin to understand that this is real. Unfortunately, with life, the lesson comes after the consequence. And it's important for us to just hear this feeling. So, sir, I can respond and say, the main reason why we are having the issues we're having today is because the preventive measures that we ought to have taken as a society were thrown out of the window. We have tremendous criticism over COVID-19 as a disease. We are not listening to what we need to listen to. We don't take this seriously until it hits us home. Unfortunately, either we listen and shape up, or it's going to hit home and it's going to hit very painfully. Because very soon, actually as it stands today, these few ICU beds that can actually make a patient with low oxygen walk home amidst tremendous difficulty, these beds are already full. And therefore, a time is coming when a patient with oxygen of 60%, who generally do much better, will actually not even have access to that facility. And if anything, we need to learn from the lesson from the West and other countries, because they are those who've gone ahead of us. Let us look at what has happened and take precautions today.
Right. All right. And I think that's very clear. And we need to start winning out of this conversation. Professor Osuru, I want to finish with you because, yes, there's a vaccination drive going on in the country. As of sometime last week, we were told that 28,000 people had already been vaccinated, majority of them healthcare workers. And even as we look for all these weapons, you hear Dr. Victor Ngani there warning that if you're not careful, then this disease will hit home and it will be too late. What do you think needs to be done? Because people, yes, are waiting for the vaccination. It may not be available for everyone. What is that magic bullet that now needs to be deployed to save us from all this?
Yeah, the vaccine program, we are happy is rolling out, but we are behind schedule if you look at the world. One thing I want to say is that in a pandemic situation, it doesn't matter whether UK has vaccinated everyone and Kenya has not. The disease will only be controlled if we have global solidarity, where if we say all medical people across the world need to be vaccinated, we do that, followed by other frontline workers like teachers and so on, followed by people at risk of severe disease. This needs to happen across the world. But now we have a situation here where a lot of developed countries have gone ahead and are vaccinating even people with no risk at all. But parts of the world like Kenya are lagging behind. We've not even vaccinated our health workers, we've just started. But even within the country, there is a problem. Nobody's talking about what we call vaccine hesitancy. Vaccine hesitancy is a situation where the vaccine is available, but people don't want to take it up. They reject it. We have seen that is among health workers, it's happening, and we know it's going to be even more severe when we go beyond the health workers into the community. There are many reasons why people hesitate. One is political. What are our political leaders saying? Are they accepting the vaccine?
Right.
If they are not, because they are supposed to be showing us the way, then I think it is not a good thing. So people will refuse it. There are also safety issues. And people are saying they have had a lot of stories about side effects. Most of these are not true. But there are a lot of things circulating in social media, and people tend to believe them. Effectiveness of the vaccine, you've had people ask, so if I have a vaccine, am I still expected to put on a mask? Or am I supposed to still keep social distance? And if you say, yes, you're still supposed to do this, then they say, then it is not necessary to have the vaccine. What people don't know is there are two reasons why vaccinations are given. One reason is because when you're vaccinated, your chances of getting infected are lower, and there are vaccines which are really good in slowing down the rate of infection when you're vaccinated. But the second more important thing is that when you're vaccinated, you are unlikely to get severe disease. And in all the vaccines that are being given now across the world, what we are seeing is you can still get infected, only that the severe disease will not be there. Getting infected with COVID is not a problem, by the way. It is the severity, the small percentage of people who get severe disease and require high intensive care treatment, and some go to the level of dying.
Right.
We need to stop this death.
Yeah, but
people need
Prof,
to understand what a vaccine is. Yeah.
All right, Prof. I had a conversation with a doctor, medical doctor, who was telling me that he doesn't feel comfortable with the vaccine, bearing in mind that it has not been tried for at least 3 to 5 years to see all the side effects, study properly, and take proper data to inform the next phase of action. Are these fears founded? And what happens? Because they are real concerns that even your colleagues in the profession are having.
Yes, my colleagues, like anyone else, need to get information. And I think maybe they have not received all the information. And that's why they could be hesitating. You know, when we were younger, I'm not very old, but when we were younger those days, it took more than 48 hours to travel from Mombasa to Nairobi using a train. It was going at a slow pace. Today, it takes how many hours? 6 hours using a train. Technology is changing. The things which we used to do for a whole year can be done in a week. These vaccines have gone through a process. There are 3 phases of studies they go through, and they have gone through those phases, and they have been shown to be safe. Every vaccine will give you some side effects. Even, you know, people who have children, if you vaccinate a child, they don't sleep that night, they cry because they are feeling some pain and fever. The body is reacting. It doesn't mean the vaccine is dangerous. It means the body is reacting. Now, when people get some of these small reactions, because the body is getting to mount an immunity against the vaccine, which will be the same immunity needed for the virus, they start getting worried. The vaccines have gone through a testing process. They have followed the 3 phases as required. It's only that now, because of technology, things happen much faster. They are safe. We know they are safe.
Right.
And monitoring goes on. Like any other vaccine, we continue doing monitoring. If there will be anything, you know, the other day, because of politics, people said, oh, clotting. We have now confirmed there is no additional clotting with the AstraZeneca vaccine. It is not any different when you're vaccinated than when you are not. Clotting happens the same way.
Okay.
So we need to stick to the science.
So what's your best advice to a person with pre-existing conditions, whether it's diabetes, high blood pressure, renal issues, and what have you?
Can I come in?
Yes, Dr. Nyikal, go ahead.
You know, you've been asking the magic bullet.
Mm-hmm.
Dr. Sur and Dr. Ngani have told you all the technical issues. Those technical issues, they are science. Science has to be applied. It has to be applied in an organized, structured system, well-funded and supported. Mm-hmm. Now, even if we leave the hard science, because that is the end bit where you're actually spending a lot more to actually just save a few people who are sick. The magic bullet is the preventive guidelines that we have been using. Mm-hmm. Now, I will say at the beginning, remember when we put very hard measures, including lockdowns, we brought this thing to below the magic. So we then have to go back and take in those measures. So. You will see that the figures will go down. That is mm-hmm. Probably we do not have to have a lockdown now. Probably we do not have to stop people from traveling, because in any case, it is all over the country now. Mm-hmm. But what are the guidelines in churches? What are we politicians doing? What are the guidelines in funerals? When people have parties, they may wear masks. Do people eat in gatherings or not?
They do.
Like in funerals, stop eating. In any big functions, people should stop eating. Because when you have masks, when you are eating, you have to put on the mask. And you look at what is happening when they go to serve. So there are clear, simple measures that will stop us from mm-hmm. getting to the point where we need Dr. Ngani to actually go and struggle with ICU. We will not release the ICU beds by actually putting more money in ICU. Mm-hmm. We will release the ICU beds by putting more measures in the preventive measures. And I'll say now, the executive, Dr. Matiang'i, we go back without violating human rights, without police brutality, and without knockdown, go down and let's be strict on social distancing, masking, sanitization, and hand washing. That is where the answer is.
Right. Thank you so much, Dr. Nyikal. And I say that we must also avoid having any conversation with anyone not wearing their mask. Hashtag no mask, no chat. We take a short break, but thank you so much, Dr. Ngani and Professor Sur. Thank you so much for joining us on this conversation. After the break, we continue with Senator Sylvia Kasanga, with Dr. Chris Omalo and Dr. James Nyikal as we focus on politics and what is informing public conversations in the country shortly.